So I've been asked to speak on using consumer information to inform clinical guidelines. And I've been a consumer representative for many years, as Ian has already pointed out, in maternity care. I have 3 children, and I've been an NCT antenatal teacher for about 24 years. So I bring not only my own experiences of birth, but also those of the women and fathers attending my antenatal classes. And I've also worked with the Cochrane Consumer Network, and with, in particular, the Cochrane Pregnancy and Childbirth Groups, because maternity care is my area of interest. And so when I've been on clinical guidelines, I've also brought an understanding of systematic reviews to the table, as well as my consumer hat. And I also, thirdly, have a background in sort of biochemistry and hematology, and so I've also been interested in the systematic reviews methodology. And I've been on 3 guidelines, 2 NICE guidelines and 1 WHO guidelines, all in maternity care. And I'm going to draw on my experience of those guidelines in what I'm going to present to you now. So I'd like to sort of look at 3 aspects. I'd like to look at how you bring consumer information to a guideline through being on a guideline development group. And then to look at how women's views can be brought to a guideline by searching the research literature. And then thirdly, I want to look at better ways of supporting consumer input. So the first guideline actually is one that I wasn't on the guideline development group. This was a colleague of mine, but this was actually, as I think, the first guideline that NICE did in maternity care. And so this actually was 10 years ago, and things have moved on and progressed a lot in those 10 years, and partly resulting from consumer participation. Because in particular, my colleague on this group argued very strongly to have 2 representatives, because initially she was the only consumer on the group, discussing obviously with clinicians and researchers about electronic fetal monitoring. And through her pressure, NICE now always have 2 consumers, and I know that Involve also recommend that you always must have a minimum of 2 consumers, because it is actually a very daunting forum for a lot of consumers to participate in. And the other impact that we had on this particular guideline was actually, it was called electronic fetal monitoring, but actually our consumers felt that actually it should be on fetal monitoring and not just on one form of fetal monitoring. And so though they didn't change the title, they actually did modify the scope of that particular guideline. So another example I've got is now from the intrapartum care guideline, of which I was a consumer representative. On that guideline we had 3 consumers, and there were 3 obstetricians. There were actually 4 midwives, because 1 midwife chaired, and then we had an anaesthetist and a neonatologist. There was one particular recommendation, well, there were many recommendations at the first draft stage, which goes out for stakeholder consultation, which caused me concern as a consumer on the guideline. But this is one that I want to illustrate, because this recommendation was that there should be an empathetic verbal assessment of the woman's pain using a numerical rating scale and including assessment of a desire for pain relief, and that this should be undertaken at the initial assessment. So that's when the woman either arrives at the hospital thinking that she's in labour, or the midwife goes to the home for a home birth. And it should also be repeated at every vaginal examination, which was being recommended 4 hourly, and at other times when they thought it might be appropriate. And this was actually to assess the efficacy of analgesia. And that caused me personally concern, because actually I would have found that really difficult in my labour, and what helped me in my labour was actually not to have pain mentioned at all, actually, but for the midwife to support me and encourage me through the birth without suggesting any forms of pain relief. So as an individual, that seemed a bit limiting, but I also knew from talking to people in antenatal classes that there were other women, coming to labour in the same way, not wanting to have pain relief, and therefore being asked to rate their pain might not have been helpful. So we undertook I organised a short survey of my local NCT branch. And I sent this message around saying that I'm asking people who have given birth what they think about the idea that has been recommended for use with women in labour. The idea is that the woman should be asked to rank their pain levels on a scale of 1 to 10, initially and at regular intervals throughout labour, to ensure that the right amount of pain relief can be offered. If you have time, I'd be very grateful if you could let me know what you think about this idea. Would it have been useful for you? And I got 24 responses, which I thought was pretty good, actually. But I will openly say this was never meant to be representative. It was just to get women's views so that I could then go to the guideline table feeling more comfortable in arguing my stance, if that's what the results showed. So about 12% of women thought that this was quite a good idea. And they said, or one of them said, I think it would be a good idea. I think most midwives find out how women feel anyway, and all women are an individual. And then some were mixed. They had mixed feelings. So one person said, quite good if it initiates a bit of conversation as well, but it could get intrusive. But the vast majority, so 80%, actually thought that this was not a good idea and it would have been detrimental for many women. And actually 25% said they would find it annoying. So some of the quotes from women in this feedback were, I'm not sure that all people can do numbers. Why not use words? It would have been totally irritated to me and brought me back into my neocortex. Not a particularly good idea, I think. And then somebody said, in my own case, a 10 rating would not automatically mean that I would want pain relief. I went through both my labours with none and would have resented at any stage being offered it or hearing the suggestion that I needed it or should have it. And then also one woman said, and this might have meant that the midwife's perception of how I was actually coping with pain could have resulted in her assuming that my ranking meant that I wasn't coping with it very well. And I could well have been pushed to try to use a method of pain relief that I actually didn't want or need. And then lastly, this quote, at some points during labour, I felt I could handle the pain. I was well supported, felt strong, believed my baby was on his way. Later, I just felt exhausted, frightened, defeated, and that was when I needed more pain relief. At both points, I think, I would have rated my pain as about 8. So for me, this gave me strong backing to go back to the group and to say that I thought that recommendation needed to be changed, and indeed it was. Now, whether other stakeholders also fed back on that one, I can't remember, because actually we got over 3,000 stakeholder comments on this guideline that had to be dealt with, and so it was actually quite difficult to check through everything. But this is where somebody on a guideline development group can bring women's views to the table. But at the same time, I was able to do it because I had a network of people supporting me. And that's not always the case for consumer representatives on NICE guidelines. So those are two ways that consumers can, or two examples of consumers contributing by being on the guideline development group. You can also get women's views if you read through the research literature. And the electronic fetal monitoring guideline became integrated into the intrapartum care guideline, and I was on that guideline. And so there was one point with electronic fetal monitoring where there were trials, these were randomized controlled trials, which had also assessed women's views and attitudes. And this then fed into a recommendation that women should be informed that continuous fetal monitoring will restrict their mobility. But there are very few clinical trials that will also assess patients' views. And so this route for information is quite limiting as well, but it is there. And then the other way that women's views came to the intrapartum care guideline was through the section on communication. And And the question that we had set as a guideline development group was, what effect does communication have on a woman's perception of her birth experience? And for that, we actually commissioned work from an expert team to feed into the guidelines. So it wasn't the research team that linked with the guideline that were doing all the systematic reviews on effectiveness. We actually commissioned people who were expert in qualitative research to bring that information to the guideline development group. And so these findings, comes directly from the guideline. These findings are usefully summarised by the words women use to describe both the midwife and the feelings involved in a positive birth experience. And these words included caring, considerate, understanding, competent, trustworthy, empathic, tender, kind, friendly, calm, alert, peaceful, having professional expertise and unhurried. And so this was really helpful, but actually what I sort of feel is that it's all been condensed into this little bit, whereas when you read what women say, it's a very rich wording sometimes that doesn't always get into guidelines. But also, you know, we only did this on this one topic area out of the whole of intrapartum care. And we weren't able to do it on every topic just because of timing, funding, all sorts of things. So it's really, this is the recommendation that then came out in the guideline from that work. And that was that all women in labour should be treated with respect and should be in control of and involved in what is happening to them. And in the way that care is given is key to this. And to facilitate this, healthcare professionals and caregivers should, and then there was a whole list of things that they should do. So even when you go to the research literature, it's still a very ad hoc, I feel, a very ad hoc way of bringing in consumer information. And there were very many other topics in intrapartum care. For example, women's views of management of pain, women's views of vaginal examinations, that just don't get into guidelines. And I'd like just to come back to how we might address that a little later. So I want to look also briefly at the support that consumers need, because actually it is a very daunting task. I found it quite daunting even with my understanding of systematic reviews and even with the support that I got from the National Childbirth Trust. And the workload was massive. These NICE guidelines take 2 years, and actually intrapartum care, I think we were 2.5 or 2 3/4 in the end, because it was so big, really. And so consumers need to sort of understand NICE process, understand how the guideline development group worked. And for example, on our group, it was a little bit unclear to me at one point how they defined consensus. So I wrote and asked the lady who headed the guideline development group, actually, and she wrote me back a letter that I didn't really fully understand. And in the end, it transpired that actually it was majority voting. And I actually thought that should have been made very clear at the beginning of the process, because it's very different as a consumer if you're in a group reaching consensus. Because when I was on the WHO guideline, that was very much consensus, but it was a much smaller topic. Whereas this one, I guess we didn't have time. And so it ended up as majority voting, and that causes all sorts of difficulties. And I also consumers also, though they are there to bring the patient perspective, they need to understand a little bit about evidence, because that's what gets talked about the whole time, the quality of the sorts of studies and this, that and the other. So it's not an easy role, and I actually think consumers need a large amount of support. And you can get the support from the guideline development group itself and from a really good chair, and that I had in the guidelines that I've been on. NICE also have a patient involvement unit, which I think has a slightly different name now. And that was extremely helpful as well. There was one person from that unit allocated to our guideline to support consumers, and I thought that was extremely helpful from NICE. And the patient involvement unit also provided training for consumers, and again that was useful, but I also then recalled my experience of consumer training on the maternity services liaison committees, where actually consumers and health professionals trained together. And I actually thought that that might be a better model, because actually it isn't just consumers being able to participate, it's actually health professionals learning to work with consumers and sometimes a bit of guidance can be useful there. And I got fantastic support from the National Childbirth Trust, particularly during the consultation phase when the draft consultation was out. We had meetings and I got lots of feedback from a much wider range of people, and I found that great. But where I did have real difficulty was actually the confidentiality that was imposed upon us from month to month until the bit where the first consultation is, and then until the guidelines published. And I can understand, and I know exactly why that confidentiality is there, but I found it really difficult because I was also not comfortable with some of the interpretation of the evidence because I've worked such a lot with Cochrane. I felt I knew a bit about that actually, and you weren't allowed to share with anybody outside the guideline development group, and I found that really difficult. And I think what I would favour, and what I have suggested to NICE but I think has not come about yet, is that if there could be a methodologist on the guideline development group itself, because when you speak with clinicians, everybody comes with their own biases, and I have to confess I have my own biases. I'm quite open to admitting that. But we had a methodologist on the WHO guideline, and I found her just brilliant, because when we were trying to make recommendations, she would say, no, she said, you can't say that because that's not what the evidence is saying. And she brought us back with our wording all the time so that our recommendations reflected exactly what the evidence said. And I found on the NICE group we didn't have that. And I actually think that would have made things a lot easier, and I think we would have produced also a better guideline. And then the other bit that I found really confusing was, we worked so hard on the levels of evidence and finding out, what was a strong recommendation, what was good evidence, and yet when you come to the recommendations, it's complete. There are no gradings on the recommendations in the NICE. There used to be, and they've taken them away, and that just I find very strange, because it seemed we were wasting lots of our time really. And as a user, you actually want to know whether this is based on high quality evidence or whether it's just the opinion of the people around the table, because the opinion of the people around the table on the intraprenatal care guideline was just a majority vote. And so I would really like NICE to bring back the grading for their recommendations. So to come back now to how we get better consumer information in guidelines, and I want to go to the guideline manual, because there is some guidance on bringing the patient perspective, and it's all around the setting of the PICO question. So actually, it doesn't really address some of the ways that you can bring in patient information as I've described with examples. And there's all these appendices, on the methodology for how you do the systematic reviews, how you check your quality of your included studies. All this methodology, actually, but there isn't anything to guide guideline development groups on bringing in consumer information and patients' views. And I would like to see them develop a systematic process that's documented in the manual of how you bring in consumer views. And I know it's not easy, and I know it's a lot of work, but I actually think that if NICE and other guideline groups are really serious about having consumer views, that actually they need to give guideline development groups a process. Otherwise, consumer information guidelines is just very ad hoc. So, just to summarise, I think it's important to have consumers on guideline development groups because they can bring consumer information to the guidelines. And I think consumer information in the research literature needs to be brought into the guidelines in a systematic way, so a documented process in the manual is needed. And I also think that support is really important from the guideline development group, from the organisation, and from people's own organisations. Thank you.
Thanks, Gill. My name's Paul Crisp with NHS Evidence, which is a service provided by NICE. I manage the accreditation programme for guidance development, and your final recommendations there just echo what we often find when we evaluate guideline development groups. An area of weakness that we find frequently is the breadth of how patients and other lay users, lay stakeholders are involved or not in the guideline development process. So we're looking at what we can learn from our experience with accreditation of what good looks like. So what are the best groups doing to systematically incorporate lay involvement? So it's not really a question, it's more of a comment, and endorse your recommendations. Thank you.
Well, it's nice to hear that NICE, because NICE have been changing things all the way down the line and trying to improve it, just taking away the grading from the recommendations seemed a retrograde step. But I think their consumer involvement, yes, and it's great, and I'm sure they are still looking to the future to see how to do things better. And I know it's not easy, because I know how qualitative researchers, spend a long, long time gathering patients' views, and it's not an easy task.
Good to hear, Paul, and I'm sure you'll take that message back and try to get it into the manual.
More of a comment, really. You mentioned about training being provided for healthcare professionals and lay members of maternity services liaison committees together. Another model is research ethics committees, where, again, lay members and so-called experts, which are the health professionals on the committee, have training is organised for those all together, and we've had some very good conversations and discussions in those training sessions, and I think they were successful.
Okay, thank you.